Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are key words or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAHDO's Director of Projects. Charles, the stage is yours.
Thank you, Sally. It's so great to be here with all of you for NAHDO's 40th birthday / anniversary of the annual conference. We heard on day one that sounds like some of the earliest meetings actually were in 1984, so maybe a little older than 40 at this point even, which I can appreciate. Thank you all for being here. Excuse me. I'm excited to introduce you to this session, Seamless Data Exchange, Real-Time Alerts, and Comprehensive Patient Journeys. The session was organized by Bechara and is moderated by Monica Cañizares with the Human Services Research Institute, or HSRI. Let me go ahead and bring Monica on stage. I'll turn the floor over to you, Monica. Thank you.
Thank you, Charles. Hello, everyone. I would like to echo the welcome to this session. I'm very excited. Today we'll have 3 great presentations that explore collaborations around data sharing and potential improvements to data sharing that can lead to better care and healthcare outcomes. So I'll go ahead and introduce our first speakers. I'm glad to present Brian Bench, State Director, and Kate Dowd, Solution Design Manager at PointClickCare. They will present on a statewide model with real-time alerting infrastructure for infection control and disease surveillance in Washington. So I'll go ahead and pass it on to them.
Hi, everyone. Very excited to be here to talk about the work that we're doing in the state of Washington with our MDRO notification and collaboration system. First, we're going to talk about who is PointClickCare. We're going to talk about why this work matters, what are some of the regulatory and surveillance framework for MDROs in the state of Washington specifically, how was this implemented, what does the data exchange and technical process of this look like, and then lastly, we'll finish by talking about what is the impact and benefit of real-time MDRO information sharing. PointClickCare is North America's largest, most comprehensive care collaboration network. We partner with entities across the care continuum to build North America's most expansive EHR agnostic network, ensuring seamless data sharing and real-time ADT notifications. Our network spans hospitals, long-term and post-acute care providers, accountable care organizations, and other risk-bearing organizations as well. We also work with ambulatory providers like primary care, behavioral health, and other specialty care. And we also work with several other different state and government agencies across the country. Let's give a little bit of background about what is an MDRO. An MDRO is a multi-drug resistant organism. They're a growing threat in healthcare, leading to longer hospital stays, higher costs, and increased mortality, with over 2.8 million antimicrobial resistant infections and at least 35,000 deaths annually in the United States. So why does this matter? This matters because if we think about the state of Washington specifically, let's look at this traveling patients map to understand behavior of patients and where they go when they choose to receive care. What this map looks at is any patient with a Washington address when they go outside of their geographical area to receive care. This is looking at acute and post-acute visits within the last calendar year. The blue is representing visits that happen within the state of Washington, and we see that a number is almost 4 million. We also see in the lines in green patients when they choose to receive care outside of the state of Washington, and that could be by choice, or if they're on vacation, or if they're referred to another hospital or another facility across state lines, that number is 66,000 or thereabouts. The reason this matters is because patients don't always stay within a community. They don't always tell people where they're going. So sometimes it can be unexpected. So there is a need to monitor patients specifically with MDRO in real time. Now, PointClickCare has identified in our national network the number of MDRO patients. This is not a comprehensive list of MDRO patients. These are just the ones that PointClickCare has identified in the state of Washington. And we see that there are 755 MDRO patients with a flag of MDRO within the PointClickCare network. And we'll talk about what that flag is in just a minute. Of those 755 patients, they represented about 1,036 ED visits within the last calendar year. 1,036 ED visits, 974 of them were in the state of Washington. 62 of them were outside of the state of Washington. So the reason for this real-time surveillance and notification matters is because we don't know where patients are going to show up, either within the state or out of the state. So let's talk about some of the regulatory and surveillance framework that we have in place in the state of Washington for this work specifically. Local health jurisdictions in Washington are responsible for investigating communicable diseases under state notification rules with support from the Department of Health for testing and centralized case flagging to coordinate MDRO surveillance statewide. Mandatory reporting and investigation of specific MDROs, including carbapenemase producing organisms or CPO and Candida auris cases, along with infection controls and medical records, enable healthcare facilities to promptly implement precautions and improve provider awareness for better infection prevention and treatment. A centralized disease surveillance system managed by the Department of Health ensures efficient case flagging, supports local investigations, and delivers real-time medical record alerts to enhance infection control and communication across healthcare facilities with better patient outcomes. So let's talk about how this was implemented and why the real-time notification aspect of this works. In the state of Washington, the Washington Department of Health shares a patient file with PointClickCare of patients with a known and a specific MDRO. With our contract and work that we do with Washington hospitals, we have also given the hospital infection control teams access to ambulatory portals or PointClickCare portals where they can see patient data, including MDRO flags. And these teams are often getting notifications like an email or a text specific when patients with an MDRO flag show up in their ED or inpatient settings. This has improved the response time for hospital infection control teams and has helped improve patient care protocols in the case of an MDRO in their hospital because they are getting these notifications in real time. So how does a clinical care collaboration part of this piece of this work? Well, Washington Department of Health, the Public Health Department, shares that patient file with PointClickCare. PointClickCare then takes that file and creates a flag on the PointClickCare national network. Those flags are shared via standard protocols, which typically fall under the treatment payment operations relationships under HIPAA. Anybody on the PointClickCare network who has one of those TPO relationships now has visibility, either in real time or through more aggregate reporting, to know when one of their patients that they are coordinating care for is in the hospital and they have an MDRO flag. So this impacts our hospital providers, this impacts our hospital infection control teams, all getting notified about these patients in real time. But it also can benefit the primary care provider who's really over coordinating care, or a case manager. They can be notified and know that when one of these patients is in the hospital, either how to help them while they're there, or post-discharge, making sure that they are coordinating care to make sure that they are safe and that they are being treated effectively. This is an example of what a real-time notification would look like for a hospital infection control team. So as soon as the ED visit happens, within a matter of seconds, we are sending this notification to that hospital control team to kick off their infection control process. Within the notification, there is a patient-specific link They click on that link and it takes them to our patient record within the PointClickCare platform. Immediately, you're able to see who is the patient, and then there's a flag of what MDRO specifically do they have, and then a short message from the Department of Health around the rules and requirements of either surveillance and monitoring, or that they need to take action specifically for this patient because of their MDRO that they have. If we think about from a hospital provider list, we're also notifying the ED providers at the point of care, thinking about the integration. PointClickCare implements or integrates a notification into the trackboard of emergency providers. So if you think of EMRs like Cerner or Epic, we embed this notification directly into those EMRs. When a patient with an MDRO flag shows up, there is a specific icon that appears that providers know that this patient has an MDRO and they need to follow safety protocols and make sure that they are keeping their clinicians and other patients around them safe. From a more aggregate reporting perspective, patients can be monitored with a 72-hour census or looking at any admit or discharge that an MDRO patient has on the PointClickCare network. Or we can look at doing more aggregate reporting to help identify trends over time, or making sure that they are closing the loop on their reporting requirements with the state health department. So knowing that there are real-time implications and real-time benefits of sharing this information, and there is a need for it, what is the actual benefit of sharing this information with providers and clinicians at the point of care in real time? By quickly sharing information about CPO and Candida auris, we can limit transmission of these highly resistant organisms, thereby protect public health. Prior to having the system in place, cases were not able to be followed longitudinally through time to ensure appropriate implementation of infection control precautions during healthcare admissions at new facilities. Investigations may identify high-risk contacts have been exposed to patients with one of these organisms. And the Department of Health may also use PointClickCare to flag these patients for screening upon admission to a healthcare facility so that infection prevention will be alerted to the need to implement screening, resulting in improved patient safety and patient outcomes. Thank you for listening.
Thank you so much for that presentation today. What a great overview of everything. Before we go into any audience questions, I want to go back to the beginning of this work. How was this collaboration initiated, or who made the connections there?
Happy to take this one, Brian. So PointClickCare was fortunate to have a relationship with the Department of Health as well as HCA. So through having that predefined relationship where we had the connected network, our relationship actually began with the COVID experience. So Department of Health, knowing that the PCC network was in place, had come to us to see how we could work together during that time. Being we were able to move their data related to COVID, they were then realizing that there was great opportunity to take that work forward around multi-drug resistant organisms. Therefore, with the network in place, partnership having been successful during the pandemic, this was the natural next step for the relationship to move forward.
Thanks, Kate. I'm wondering, you mentioned about the infection control teams getting notified. Do you have an awareness about how long it might have taken before the system was in place for them to be notified and be acting at the healthcare facility?
Anecdotally, the information we were receiving is that it was really on the patient to self-report. So it was basically hit or miss if that information was coming through them. There was lots of work done by Department of Health to have regular contacts with all infectious disease providers throughout the acute settings of the state, but it really did often come down to patients' ability to self-report.
Right. I was wondering about patient education during the presentation. So were there any conversations when planning the collaboration around patient education as well, or is it really focused on getting the providers that notification?
It was really focused on getting the providers the information in real time to the point of meeting regulatory requirements for notification of known multi-drug resistant organism at the time of admission. With that said, Washington State is tremendous with the ways that they do interact with patients on a regular basis and the way that they do their best to be informed by the public and Washingtonians on all initiatives that they do. So I wouldn't want to say that they didn't talk to them, but we on the technology end were specifically working around the workflows of what is best for both the Department of Health as well as those end users, i.e. the infectious disease specialists within the acute setting.
Thanks, Kate. So going to the technology, what are really those infrastructure components that were critical that PointClickCare set up to making this collaboration a success?
Being Brian did the whole presentation, I'm going to keep taking all of these, and that would be is that we had the privilege of working with the state by having the real-time care coordination network connected to all the acute facilities throughout the state. So what that means is that we're able to take real-time admission, discharge, and transfer data when a patient checks into any hospital or skilled nursing facility, for that matter, in the state of Washington. When they say yes on their HIPAA documentation, those electronic medical records automatically release the data to our database. And so having that technical infrastructure of the network is how this really became an opportunity for Department of Health, both in the pandemic and then moving forward to the NDRO, because the data was already moving and all of the providers were connected through that. So the state was just taking the opportunity to build on top of the technology that was already embedded in the clinician's daily workflow. Those connections of when that all stood up was really back in 2012 when the state of Washington was doing their ER for Emergencies initiative. So they've had many years of leveraging this technology for clinical workflows, and they just keep improving how they choose to leverage and what type of additions like this they add to the network in their state.
Great. So using that in new ways, we could probably circle back to that if we need more questions in the end. But I have a question from Kevin in the audience. In Washington, have you used APCDs to help ID MDRO patients? So this might be more broadly separate from the real-time alerting, or maybe a collaboration. Has the all-payer claims database been used to identify these patients?
That would be something I would need to deep dive with the Department of Health. A lot of times they are using every single data source they have available to them. That, I believe, would include, as they are part of the member list of NAHDO, accessing that data. Additionally, I believe they're also using real-time labs, being there are specialized labs in pathology associated to the multi-drug resistant organisms. I suspect that they are taking all of those data sources to compile that single list that they submit to the PointClickCare network. So to the point of they're using multiple modalities of identifying individuals to ensure that anybody, especially those colonized living long-term with these, have, again, to Brian's point, the longitudinal attention that they are needing.
Great. Thank you, Kate. And Kevin adds, I'm asking because Oregon's APCD has been asked to be a source for similar alerting. So maybe we've reached our time for this, but we'll bring back Brian and Kate at the end, and maybe we can talk about lessons learned to pass on to other states regarding this. So thank you both for those insights. I'm excited to bring you back on in a few minutes. So next we're going to hear from Kimi Landry, a research and evaluation analyst at Civic, and her work on perinatal care for neurodivergent populations using claims data from the Colorado All-Payer Claims Database.
Hello, everyone. Thank you for joining me today. My name is Kimi Landry, and I'm a researcher at the Center for Improving Value in Healthcare, or CIVIC. Today, I'm going to be sharing work from our team, the Research and Evaluation and Innovation team. This project is titled the Colorado Autistic Perinatal Experience, a claims-based study of pregnancy and delivery. And this project is really part of our ongoing work to uncover health disparities using the Colorado All-Payers Claims Database. So, CIVIC's mission is to equip partners and communities across Colorado and nationally with data and insights needed to improve healthcare quality and equity. Our vision is simple but powerful, that everyone has the opportunity to be healthy with access to equitable, affordable, high-quality care. This study reflects that vision. It's about shining light on populations our health data systems too often overlook. So the Colorado All-Payers Claims Database includes medical, pharmacy, vision, and dental claims data covering over 70% of Colorado's insured population from 2013 to 2025. It contains over 1.3 billion claims from 33 commercial insurers, Medicaid, and Medicare, and is updated monthly. The COAPCD does not include specific items, including some ERISA-covered self-insured plans, TRICARE, Indian Health Service, and then the uninsured. So why this study? Why did we do this study? Autism and other pervasive developmental differences affect communication, sensory processing, and how people experience the world. Yet most health systems weren't designed with neurodiverse needs in mind. So that mismatch can lead to, and has led to, miscommunication, unmet needs, and poor outcomes, especially during major life events like pregnancy. So despite all we've learned about maternal and perinatal equity, autistic parents are still almost invisible in those data conversations. And that invisibility is what really motivated this work today. So for this analysis, we use both the current autism spectrum disorder diagnostic codes as defined in the DSM-5 and the older pervasive developmental disorder codes used before 2013. We included both categories to ensure complete capture across our 10-year data set because diagnostic language has evolved, but the individuals behind the data haven't changed. So this decision helped us bridge sort of the pre and post DSM transitions and minimize missed cases due to coding variation. So before diving into results, I think it's really important to acknowledge language. In this study, we use autistic individuals rather than individuals living with autism. And this really aligns with preferences from most of the neurodiversity community. It's a small linguistic shift, but it does matter, and it recognizes autism as a part of identity, not a condition to distance from. So our goal today was to describe pregnancy and delivery trends among autistic individuals in Colorado using the COAPCD. So we analyzed 10 years of data, 2013 through 2023, using retrospective cohort design with the Johns Hopkins ACG system. We stratified by age and insurance type to better understand differences between Medicaid, commercial, and Medicare populations. And the total population we identified with pervasive developmental disorder diagnosis was just over 10,500 individuals. And about 3,000 of these individuals met the definition for autism spectrum disorder, making up 29% of the broader PDD cohort. So one of our first key findings is when we look over time or saw trends over time, the number of pregnancies among autistic individuals increased by about 122% between 2013 and 2023. Now, I want to point out that the population was small, 531 to 1,182. But the steady growth is something that does matter, and it means more autistic people are navigating pregnancy and delivery, often within systems that may not yet be prepared for their unique needs. And another one of the most critical findings that we noticed was that over half of pregnancies didn't have a matching delivery, as you can see from this slide. And that mismatch doesn't necessarily mean adverse outcomes. Some of it may reflect coding differences, incomplete data capture, or deliveries occurring outside of traditional claim systems. But it does signal possible breaks in the continuum of care, pregnancies that begin in the healthcare system but aren't always followed through to documented delivery. So in practical terms, that could mean missed follow-up, untracked outcomes, or gaps between maternity care, between maternity, behavioral health, and hospital claims. But it's one of the clearest examples in our analysis of how neurodivergent parents can fall off the map, so to speak, in our data infrastructure. Demographically, most pregnancies occurred among younger individuals, and the majority were covered by Medicaid. This group also had higher vulnerability scores based on their ACG risk profiles, suggesting greater medical and behavioral health complexity. That combination, youth, public coverage, high vulnerability, is a critical intersection for understanding care continuity and postpartum support. So, what does all this mean? This project really made one thing clear. Our health data infrastructure wasn't built to see neurodivergent adults, especially during pregnancy. Diagnosis coding is often inconsistent, and once individuals age out of pediatric systems, autism rarely appears in claims. Even identifying this population took careful validation and cross-checking, a reminder of how easily people can disappear from data. And that invisibility is both a challenge and an opportunity. By linking claims, electronic health records, and social data, we can illuminate experiences that traditional systems miss and design care models that better meet neurodiverse needs. Data can show us where the gaps are, but only if we ask the right questions. So what's the takeaway? We can't close perinatal equity gaps without acknowledging neurodiversity as part of the equity conversation. Inclusion in data is the first step toward inclusion in care, and visibility begins with how we collect and classify information. At Civic, we're committed to improving that visibility by refining data capture, linking sources, and partnering with researchers and communities to build a fuller picture of health in Colorado. Some references. Thank you again so much for your time and attention today. I'd be happy to connect after if you'd like to discuss. Thank you.
Great. Thank you so much, Kimi, for going over that. I was wondering at the end, your takeaway is improving visibility for neurodivergent population patients and the data. Could you speak a little more to what those next steps might be for just some more specificity for that?
Yeah, absolutely. So, as you can see, we did not have a partner for this project. So I think absolutely partnering with community organizations and clinical people that work with this population would be really important and essential. Having the opportunity to integrate electronic health records and survey data for this population, I think would really help us discover more of the population in claims. It was very difficult to sort of find these people in claims data. I think integrating more electronic health records, a community partner with a lot of background with this population would be really essential to help improve visibility in the data and the system as a whole.
Besides the change in coding, what were the other challenges in identifying the population, like not having diagnoses, or where were those challenges stemming from?
Yeah, so our focus was looking at perinatal care and really finding an autistic diagnosis during perinatal care time period is difficult. So a lot of people who are going through the perinatal care period, they're not also getting diagnosed with autism at the same time. So we really needed to go further back in these members and look at a further longitudinal period of claims and episodes with them. And that's where the ACG system really helped us with like the pregnancy and delivery grouping, but also really refine the autism sort of diagnostic codes and making sure we were pulling in as many people as we possibly could with that diagnosis, and then also had a pregnancy episode.
And how could better data on autism in the perinatal period or during pregnancy help inform more equitable outcomes for perinatal care models?
Yeah, absolutely. So I think even though, this population is small in claims, we know, based off surveillance that they are a growing population in terms of, people identifying as being autistic. So even though we don't see them in claims, I think, sorry, will you repeat your question one more time? I just had a little brain fart moment.
That's okay. How could improving the data, so we talked about improving it, how would that lead to better care models?
Yeah, so definitely. I think studying groups and populations like this that we know are growing surveillance-wise and looking at them in claims, that would help not only improve the outcomes of that population, but it helps improve outcomes for everybody. It helps inform clinicians and the healthcare system as a whole to think of everybody as an equitable one system approach.
Thanks. I'm going to encourage the audience to think about what other invisible populations you think there might be. So we've heard, about autistic individuals during perinatal period or overall as older or as adults. So throw that in the chat there. And one more question for Kimi for you right now. What is next steps for this data? Have you shared it, or where are you hoping to see impact?
Yeah, so we've had the opportunity to present this data, a handful of times now. And I think that's a great first step. But now the next step is, kind of like I said at the beginning, we would love to engage with a community organization and take this data a step further and really work with the population that this could really impact and help. Unfortunately, funding comes into play. So, our next step is hopefully to gain funding. We're doing a lot of work in the maternal healthcare space, and I think that is a huge research field right now for very important reasons. So, I think our next steps would be hopefully to engage with partners and other organizations that would be interested in working with us and sort of bringing data sources together, because I think that's what would be essential to sort of bring this to the next step.
Great. If your organization wants to connect with Civic and Kimi about this work, please reach out to her. Thank you, Kimi. So we'll move on to our last presentation for this session. Our last presentation is by Megha, a Senior Evaluation and Research Analyst at Civic, and she will present on a novel approach to identify hospice utilization using claims from the Colorado All-Payer Claims Database.
Good afternoon, one and all. My name is Megha, and I am a senior researcher at the Center for Improving Value in Healthcare, or Civic. Today's presentation topic is hospice care in Colorado, a claim-based identification approach. This topic is a part of the larger end-of-life portfolio work. It is a small exploration done by my team and me to understand hospice care claims using the Colorado All-Payers Claims Database, or COAPCD. Before I dive into the topic, I want to talk about Civic briefly. We are a nonprofit, independent organization. Our role is to provide partners with resources, services, and unbiased data they need to improve health care and health outcomes in Colorado and beyond. Our vision is that everyone has access to affordable, equitable, and high-quality care. That commitment to equity is central to work I am sharing today. The Colorado All-Payers Claims Database, or COAPCD, includes medical, pharmacy, and dental claims data, covering over 70% of Colorado's insured population from 2013 to 2025. It contains over 1.3 billion claims from 33 commercial insurance, Medicaid, and Medicare, and is updated monthly. Key exclusions are ERISA-covered self-insured plans, TRICARE, Indian Health Services, and the uninsured. Despite these gaps, I really believe that the COAPCD is a critical resource for analyzing healthcare costs, trends, and outcomes for the insured population in Colorado. The background of this topic: the potential positive impacts of hospice care are complex and challenging to quantify. Although patients who do not receive hospice care are more likely to have costly and unwanted end-of-life care. Hospice analysis generally uses EHR, or Electronic Health Record Encounter data, or CMS hospice care population level benchmarking, which are incomplete. So our research objective was to validate a new methodology for identifying hospice care in claims by matching patient hospice care indicators on death records with healthcare claims database data in Colorado APCD, providing a descriptive population analysis, a future cost-benefit evaluation of hospice care utilization. The study design for this topic: it is a retrospective observational study done on end-of-life cohort. We linked COAPCD data with Colorado death records received from CDPHE. Cohort contained members who had died between 2018 to 2021. Claims of the last 4 years before death of such members were used. CDPHE matched COAPCD data and provided members' cause of death and if they were enrolled in hospice care at time of death. On COAPCD front, We flagged hospice care claims using place of service 34 code, CPT hospice codes ranging from T2042 to T2046, as well as bill type codes 81X and 82X. This was done along with hospice provider taxonomic codes in COAPCD. The filters used to create this cohort were inclusion criteria like members who have died in between 2018 and 2021, members with 18 years or older age, members having more than 6 months of healthcare coverage before death, and they also having 50% of healthcare coverage in last 3 years before death. Exclusion criteria were like traumatic deaths, people with claims after they had died. If they had more than one claims after they had died, we removed them. And lastly, people without 6 months of eligibility before that. We wanted to capture the healthcare needs of this population, especially end-of-life care needed for this population. So our population, the overall set was 94,475 COAPCD members. Among these, 39,420 or 42% of the total had at least one hospice claim in last 4 years before death, while 47,808 members had CDPHE flag. Moreover, not all members with CDPHE flag had hospice claim, and not all members with COAPCD hospice claim had CDPHE flag. This discrepancy was one of the reasons why we wanted to do this study. As stated before, 47,808 or 51% of cohort had hospice CDPHE flag, meaning they were in hospice care at the time of death. Many members can be in hospice care but can also have other types of claims like inpatient or facility. Unless specifically marked or billed, these claims are not flagged as hospice care on claim side. Among 47,808 members with CDPHE flag, only 27,664 had a hospice claim in our data, a match rate of 58%. This is considerably a high match. We then looked at the payer patterns for this population. As shown here, largest group of our study had Medicare fee-for-service insurance. Dual eligibles, people with both Medicare and Medicaid insurance, were second largest, followed by Medicaid. These patterns likely reflect differences in awareness of benefits, referral pathways, and coverage design. Finally, most of hospice claims occurred during the final year of life, aligning with the hospice eligibility requirement of a life expectancy of 6 months or less. Medicaid members tended to receive hospice care the year or two before death for a longer average length of stay than other insurance payers. This observed pattern in Medicaid members may signal the presence of chronic life-limiting conditions, underscoring Medicaid's role in supporting more extended end-of-life care for individuals with complex needs. The claims hospice methodology employed by my team, when linked to death records, provided an accurate understanding of hospice care that aligned with national averages. Variation across health insurance payers suggest differences in access, awareness, and referral patterns. The expansion of eligibility and encouragement of earlier hospice engagement, particularly for individuals with chronic, progressive illnesses, may enhance end-of-life, quality of life, improve equity, and reduce unnecessary interventions near the end of life. So in conclusion, linking COAPCD claims with death records provide a comprehensive and accurate picture of hospice utilization in Colorado. This methodology successfully captured utilization across payers, revealing essential differences in volume and timing of care. Higher utilization among Medicaid and Medicare members may reflect greater familiarity with benefits targeted advocacy, or differences in referral patterns. These findings provide a foundation for policy and practice changes aimed at providing or improving equity, access, and timing of end of care in Colorado. So here are some of the references which we used for this study. Thank you everyone for joining me today. I would like to take any questions or feedback or suggestions you have for me at this time. You can also reach out to me at mjha@civic.org for any future discussion, or connect with us using one of our social media pages or our email list at www.civic.org. Thank you.
Thanks, Megha, for presenting on that to us. I wanted to ask, before we dive into technical details, how does this fit into, you mentioned this is part of Civic's end-of-life portfolio. How does this fit into that work?
Monica, that's a great question. So at Civic, we have been working on end-of-life work for last 3 years now. Last 1 year and a half, once we have gathered a lot of information, reaching out to multiple stakeholders and subject matter expert, we started deep diving into multiple measures, utilization and cost for end-of-life population. This hospice care claim was one such a part of the retrospective study. Since this is a retrospective cohort study, we're trying to come out with multiple outcomes, what we are seeing on our COAPCD front. Having said that, when we deep dived into end of life claims, we figured out there were a lot of healthcare gaps and a lot of claims discrepancy around such measures like hospice care, advanced care planning, and palliative care. So this was our stab at understanding hospice care claim, because at the first time when we had done this, our percentage pull from the COAPCD claims for hospice care was quite low. So we had to reach out to providers, multiple subject matter experts, other members from other different APCDs to understand how they are going forward with this. We gathered all this information and implemented that for the study and came up with a percentage match. What we see from the CDPHE front, the 51% which they have sent, is kind of synonymous with what hospice care registry shows, but we were not seeing on the claim side. And hence we deep dive and try to match what the population from death records are showing on our hospice side or CAPCD side and vice versa.
Thanks, Megha. That's great. When you did that linkage with the death records, what kind of checks were in place for quality? How did you ensure accuracy there?
What we did, we have a very good working relationship with Colorado Public Health Department. So what we did for this study was, after the contract signing, we sent them a huge member enrollment data with anybody who is 18 years or older from 2018 to 2020, 2022 or 23 for the study. They matched it on their front using the IDs which we had sent them, and then they send us back. We have a very secure portal system to send data and receive the data from them. Once we receive the data, we want to be sure again that we are seeing those exact members on our front. And so we rechecked those members on our front, and we might have to remove some of them based on some discrepancies which we were seeing in our cohort. So this safe portal system and usage of multiple matching, one from the CDPHE side and then one from our side, validates the end of life population. And then this further research we did on the hospice care population.
Great. We have a question from Asmita in the audience. You mentioned that Medicaid patients often stayed in hospice longer. Why do you think that is?
That's a great question. Medicaid population, what we see in our cohort here is Medicaid and Medicare both. Means it's a geriatric skewed population because it's an end of life population. But what we see from the Medicaid side, they have members who who have slow chronic illnesses. So the health decline is very slow. So they do tend to avail hospice care sooner than any other payer types. And hence, since they avail hospice care sooner, they tend to have proper usage of the healthcare needs they have, and which helps in better quality of life during end of life period for these members. Um, and Medicaid has a great system of putting people into such kind of hospice care, palliative care system, so that they can avail the necessary minimum they need for their life to go on.
Thank you. I wanted to ask about identifying hospice care in the claims data. Are hospice care and palliative care, do those ever overlap in how you see them in the data, or how do you distinguish between the two?
That's a very great question, Monica. I would speak about hospice care claims first and then bring the palliative care. Hospice care claims, according to multiple subject matter expert and people in APCDs whom we have spoken to, they tend to use 3 or 4 different methodology. So we try to incorporate all of them to pull in more members or more claims for such members. First one was place of service code, which is 34, which is in a hospice care settings. Second of them, claims with the bill type codes 81X and 82X. We also had hospice care CPT and hospice codes, which was T2042 to 46. And lastly, we also pulled in hospice care provider taxonomy codes. So we wanted to see who's providing them, if they are flagging it, or it is flagged on the bill types, or it is flagged through the place of service setting. Uh, Many a times what we saw is they do get the services in the hospice care setting, but they are flagged as an inpatient, or they are flagged as some other type of claims. The billing system is not very consistent. That's how we pulled hospice care claim in CAPCD. As for palliative care, we do have some codes for palliative care as well. But what our cohort study found out in last few years is palliative care is not flagged as much as any other care is flagged. Means the number percentage was so low that we had to reach out to providers to understand. Some of the understanding is that many providers, although they do palliative care, they are marked as physician, or they are marked as some other providers. So on our claim side, we see them as physician claims, not palliative care provider claims. So this is one of the challenges we have on our claim side to flag such members and the claims usage.
Thanks. Thank you for talking through that. Well, I'll go ahead and invite all of our panelists back on screen for some final questions. Please keep them coming to the audience. If you have any, this is your last chance, or you can connect via the platform as well. I'm going to go back to the title of our session. So our title is Seamless Data Exchanges, Real-Time Alerts, and Comprehensive Patient Journeys. I'm wondering, what are those seams or bumps that you worked through while moving your work along? If we could hear from each of our presenters, just what are some of those things that you worked through or are currently working through still? And we can start with, I'll just go to the top. Brian and Kate, if y'all want to speak to that.
I'm happy to. Again, supporting our partners, the Department of Health, and whatever they need. Again, to the earlier questions, it takes a lot of work for them to maintain that file and get it to us, as well as all of the great relationships that they have with the infectious disease specialists across the state. People move on, people change jobs. So being able to stay on top of who is receiving those notifications and is going to take action, it could be a lot. So I feel like there is always continuous work to keep this up and running. And some of that is out of the control of our partners at the Department of Health and us as technology, right? So offering continuing education access to those clinicians has been imperative to keep this going.
Great. Kimi?
Yeah, so I think some of the big humps that that we need to work through is not having that full picture of that patient journey throughout in claims, and seeing that discrepancy between pregnancy and delivery, at least in my study. That was still something that I'm still trying to understand and work through, because you can't see, what happened during a lot of this period. And so it's a hump and bump that I, would love to continue to evaluate and sort of investigate. But hopefully with funding and an opportunity to work with a partner, we can get that going.
Great. Megha?
Some of the humps, which I kind of mentioned, like we had to figure out how the claims are flagged. So having said that, the earlier we talk to any policy implications which we can do through this, so that we see more of such flags, so we would know what is the actual utilization and cost implications for the state or for the healthcare providers. Having said that, a major hump we also found out was community partners and providers, they don't have early discussions with their patients or the members. Early discussions would lead to early usage of such services, and the end of life population is already so vulnerable, and by the time they get to know about hospice care services, it's kind of very end. And that's why one of our criteria was to see 6 months before death, because that's the criteria for hospice care as well. And as you can see in our data set, we still have not pulled 50% of our hospice flags from the CAPCD side. We had to merge that with CADPHE flag to understand, okay, our population is using this, but we are not seeing on the claim side. So seeing the visibility on the claim side is needed for future any implications or any policy changes.
Thank you all. Everyone's been speaking about collaboration and either who you would like to connect with or who you've consulted with or who you're working with actively to implement this work. So just wanting to see what either data systems or collaborators are you hoping to bring to the table next to move this work forward? We'll start with you, Megha.
We have spoken a lot about this, and funding is one such thing which kind of hinders a lot of movement. But we would like to bring in hospital EHR data for one's facility to see if they are serving hospice population, and we are seeing on the CAPC side, and if we can bridge this gap which is present right now. Once we use this for such facilities or some community partners to see this on the claim side, then we would be having more strength and have more power in our analysis as well as outreach to other partners or members to do this kind of work and see where we can pitch in to serve community at large.
Thank you. What about you, Kimi? What data or partner are you hoping to bring in?
Yeah, I think Megha definitely hit on it already with electronic health records, but definitely also subject matter experts in autism and the neurodivergent field. We like to say that we're the data experts. We are not the experts in every single health care outcome that we try to research. So, I think this study could really benefit from collaborating with an autism expert or a community organization that works with autistic individuals, and neurodivergent individuals. So, but funding again as well. So collaboration we would love to do.
Great. And Kate and Brian, any future collaborations or partners you're hoping to bring in?
Yeah, I think PointClickCare is in a unique spot where we're a care collaboration organization. Primarily, we do have unique data sets where we have a very rich EHR on the senior care side, but also we have acute ADT on the acute side. So our lens is not necessarily data aggregators. We're looking to help how we can bridge data to help clinicians at the point of care. And so it's really connecting with the Department of Health, like in Washington, but other organizations like public health and counties and things like that to really understand where is there a need for real-time data. And so we're thinking about putting that head on. This is a very narrow use case that we do, but there could be other use cases as well where we need to better understand and collaborate with our community health partners in the states that we work in to see, is there a way that, or a need of how we can help address using real-time data to help care collaboration and drive that further to help patient care and patient outcomes.
Great. Well, thank you all. That's the end of our session. I really appreciate the time you took to presenting to us, and pass it to Charles.
Thank you, Monica. Let me express our gratitude to Josie Bechara at NORC for organizing this session, and to you, Monica, for moderating. Of course, thank you to all of our speakers, Brian, Kate, Kimi, and Megha. Excellent work. Thank you. And we appreciate all of you for joining us. Next up is the closing plenary. And we are going to talk about the APCD-CDL, a deep dive into the blueprint for collecting claims and non-claims payments data, a topic near and dear to my heart, with my friend Janice Borgo. So I'll see you all over there. Thank you. Have a nice rest of your day.
Thanks, everyone.